My name is Donnie Hours. I'm a primary care sports medicine physician. I've recently joined the Washington Health System. Concussion is injury commonly seen in contact sports. It's due to a force transmitted to the brain either directly or indirectly. It has a pretty high incidence. It's estimated 1.6 million to 3.8 million sports-related concussions per year. We also classify it as a mild traumatic brain injury. And also it is a functional brain injury rather than a structural brain injury. And I say that as sometimes we'll get imaging such as CT scan or MRI, and we will not see any evidence that would lead us to the diagnosis of concussion. We sometimes do get imaging to rule out other serious brain pathologies such as a brain bleed, skull fracture, and things like that. The gold standard of treating concussion is through the signs and symptoms that we observe and are reported by the athlete. The signs and symptoms of concussion, we like to categorize them into 4 different categories. The first one being somatic or physical symptoms such as headache, dizziness, sensitivity to light or sound, also nausea and vomiting. Cognitive symptoms such as difficulty focusing or concentrating, memory, forgetfulness, things like that. The other category is emotional. We sometimes see patients that will become irritable, sad, and have depression-like symptoms, and also sleep disturbances, either increase or decrease the amount of sleep that they need, or insomnia. So there's a myth that in order to have a diagnosis of concussion, you need to have a loss of consciousness, which is false. We do have student athletes that will lose consciousness with concussions, but it is not needed to diagnose a concussion. One of the ones that we're most worried about is a condition called second impact syndrome. So what occurs is we'll have an athlete that sustains a concussion during a game, doesn't get removed from play, goes back in, and sustains another injury to that area of the brain that's been damaged. And what happens is that area of the brain is more susceptible to injury, and that can cause swelling in the brain. And as we know, the brain sits within the skull, and there's not a lot of space for the brain to swell. And what can happen is the actual brain tissue will herniate down to the spinal canal, and it can cause permanent brain damage and sometimes even rarely death. And that's one of the reasons we want to be aware of our athletes that have concussion and remove them to play in order for their brain to heal. The other complication that we worry about with concussion is if left untreated, patients can develop chronic symptoms such as chronic headaches, chronic vertigo. The gold standard for diagnosing concussion is through signs and symptoms observed. Right now, there's a lot of different research going into blood tests, imaging to help diagnose concussion. They are currently being researched, but none have been validated. So we use what we hear from the student athletes and their physical signs and symptoms to diagnose a concussion. We also use eye movement test and balance test to help us come about a diagnosis of concussion, and if available, neurocognitive testing that's usually done in the preseason such as impact can be used. And what we do there is use the scores that the patient had before injury or in the preseason, have the patient redo the test and compare how they do on a test when they suspected of having concussion to prior when they did not, presumably. Treating concussions, I believe, is a team effort, and it needs input from everybody around our student athletes, including medical providers, athletic trainers, coaches, teachers, and parents. The first step when treating a concussion is to recognize a concussion has occurred, and the first thing we want to do is to remove the athlete from the field of play. One of our rules in sports medicine is when in doubt, set them out. So anytime I suspect a concussion in one of my student athletes, they are not allowed to return to play on the same day before we can get a full evaluation and be sure that a concussion has not been sustained. And this goes into awareness with coaches, referees, and trainers, that they're all aware of the signs and symptoms of concussion. And when we recognize a concussion, is to remove them from play. So after we remove the athlete from play, the next step is rest and monitoring signs and symptoms. Now, the first visit I'll have with our student athletes, we actually give them a scorecard and they will rate their symptoms on a scale 0 to 5 with many different symptoms that can occur in concussion. And we use that to follow the athlete along to ensure that symptoms are getting better and we can kind of note their progress in healing. Also, in the first 24 to 48 hours, we want to monitor symptoms at home to make sure they're not getting worse, that they're actually getting better, and there's no suspicion for a more serious brain pathology that's going on. And that's where the parents come into play to know the signs and symptoms and let the medical personnel report that. Also in our college level athletes, roommates, teammates come into play and kind of be our inside man when it comes to what's going on with the athlete at home. So one of our most important goals is to get the student athlete back into school, and this is where our teachers come into play. I use a metaphor with my students that if you had injured your knee, we don't expect you to go around and run a 5K. And that's the same thing with our brain, is the exercise of our brain is schoolwork, so we wouldn't expect you to go full force right back into school. And some of the common accommodations that we have for the teachers is to allow our patients to wear sunglasses in class when they're having sensitivity to light, letting them leave the classroom early and get to their next class before everybody's released to move to the next class because of sensitivity to noise. Also, we'll sometimes have the patients go, a half day until they can tolerate being at school the entire day. Also, when it comes to testing, sometimes it's unfair to have our, concussed patients to do a full-fledged test. So sometimes we'll try to push those off or give the patient more time with these tests. And sometimes it's hard to get a good communication between the medical side and the teacher. So we usually perform an accommodation form that spells out these accommodations and gives them kind of a guideline to help with our students in school. So at home with the parents, we've come from a theory of what we call Cocoon Therapy, where we put the student athlete in a dark room, have them do nothing, and wait till the symptoms go away, which research have shown actually can sometimes prolong symptoms. And the reasoning is most of our patients that have concussion are teenagers, and a lot of their daily life is socialization. So putting them in a dark room, isolating them, can exacerbate symptoms such as depression, and that has the opposite effect of what we're wanting to do. So I have a saying when with our patients is, if it bothers you, quit doing it. It simplifies what we're trying to get at, but we want our student athletes to be able to socialize, use phones, watch TVs, but under the understanding that if it is exacerbating our symptoms, we need to stop doing that. And everybody's going to be different when it comes to that. And I try to emphasize with my student athletes, you have to be honest with yourself and your body, because if you push it and you're having the symptoms, it can prolong your recovery. And most of my student athletes are eager to get back to play. This is where athletic trainers have a very big role. They see the patients day to day and they can follow the return to play. And how we usually do it is a very structured, stepwise approach back to full contact sports. The first level, we want the patient's symptoms to be managed and not affecting daily life when they're at rest. When they've done that, we move up to walking, light jogging, and continually move them up until we get to a point where we're ready to get back to full practice and contact. Along the way, if we're getting exacerbation of symptoms, we stop and stay at that level until symptoms are managed, and then they go to the next level. And that's where the athletic trainer really plays a pivotal role. Another question I get asked a lot is, how long is this going to take? When can I get back to play? The textbook answer would be anywhere from 2 to 4 weeks. Our younger patients, it seems like takes longer to recover, but ultimately the brain's going to tell us when it's ready for a return to play. And what I mean by that is, once signs and symptoms are not occurring with activity, we know full healing has occurred and we allow them to go back to play. So there's a lot of different products that you may see online marketed to help decrease incidence of concussion or protect against concussion. Currently, a lot of the studies that have tested these products have not shown to help decrease concussion. such as headbands worn in soccer for heading, mouth guards to help absorb the force going to the brain, and also football helmets. Football helmets are mostly there to protect for skull fractures and not so much with concussion. Other studies have also shown that some of these products, such as the headband, promote a more aggressive play where the student athlete feels like they're more protective and plays more aggressive than they would without. So I think the biggest thing for medical providers is to spread awareness and education to help the community, coaches, referees to recognize concussion and get those student athletes removed from the field of play, and also to get them in to be evaluated and get appropriate treatment. To make an appointment with me for concussion or any other sports injury, give us a call at the Washington Health System Orthopedic and Sports Medicine office.